Great to have you all here, and it's also great to have the abundant support of our fine audiovisual team that's going to be recording this in posterity, as have all of our lectureships for this special year been. For those that I don't know, I'm Barbara Bass, and I have the great privilege of serving as the Vice President for Health Affairs and the Dean of the GW School of Medicine and Health Sciences. And I want to welcome you officially to our fourth and final faculty lecture series event of our bicentennial year. As you know, today we are featuring our colleagues, Dr. Karen Fagan and Dr. Mardi Gomberg-Maitland. And as you may also know, these presentations were selected based on a proposal that was received by the committee that selected our colleagues to talk. And they sent a most compelling proposal. So thank you for that. And we'll be hearing a little bit more about what you're going to talk about shortly. I do want to highlight for the group, because we've had a different group every time, that this is our bicentennial year. We're wrapping it up right now. We've been celebrating this since really a little over a year now. And it means that actually for 200 years, we've been training many generations of talented and compassionate physicians, scientists, and in more recent decades, we've had a lot of healthcare leaders in multiple professional disciplines, such as our physician assistant program, our physical therapy and occupational therapy programs, and of course, our PhD researchers in biomedical sciences and laboratory science leaders. So we got quite a repertoire going on here for these last 200 years. We're going to be wrapping them up this year, with two closing events. On March 26th, which is not too far off, we'll commemorate the 200th anniversary of students who attended their first medical lectures 200 years ago. And on March 27th, sort of as our final wrap-up celebratory event, we're going to hold a special faculty and staff awards event recognizing outstanding service to our academic medical enterprise with a number of honorees across all of our disciplines, faculty, staff, and others. And that is an inclusive event, which includes all in GW Medicine, SMHS, the MFA, and others. When we launched this faculty lecture series this academic year, our hope was to really showcase the talent we have from within. You know, we often have wonderful people come and visit us from outside, but that means we don't get to spend time with our own incredible academic leaders and talents. And so it's really particularly very nice that we have Dr. Fagan and Dr. Gomberg-Maitland to carry on this tradition. And their talk, which I'll talk a little bit more about in a minute, is called High Hopes and High Pressure, a timely look at pulmonary hypertension, a most clever title, but we look forward to that. And as I mentioned, we did pick these based on a call for proposals, which we did last summer. And I got to say, we've had just three so far, and I'm sure a fourth wonderful one to wrap up the series. I hope that most of you have had the chance to meet Dr. Karen Fagan. She is our relatively newly arrived chair of the Department of Medicine, the Ellen Zane Bicentennial Professor of Medicine. She joined us in September. She's a pulmonologist, for those who don't know, and a professor of medicine here with us now. She joined us from the University of South Alabama, where she held the Tanner Chair in Pulmonary Medicine and was chief of the Division of Pulmonary and Critical Care Medicine and the director of the Pulmonary Hypertension Center. And she served as interim chair of medicine before coming here to GW. Dr. Fagan earned her bachelor's degree in biochemistry and cellular biology at the University of California at San Diego at the Angela Davis College. She then completed internship and residency in internal medicine at the University of Texas Southwestern Medical School and Parkland Hospital. She went on to complete her fellowship in pulmonary disease and critical care medicine at the University of Colorado Health Sciences Center, and then joined the faculty at Colorado, rising to the rank of associate professor before being recruited to South Alabama. She is widely recognized for many talents, but especially for today is her research on understanding the pathobiology of pulmonary hypertension. Her work has encompassed understanding the role of vasodilators and vasoconstrictors in pulmonary hypertension with a focus on potential therapeutic options. Dr. Mardi Gomberg-Maitland is a well-known to our community cardiologist and professor of medicine at the George Washington School of Medicine and Health Sciences here. She is the Walter G. Ross Endowed Chair of Clinical Research and Chief of our Clinical Research and the Chief Clinical Research Officer for our Office of Clinical Research, a relatively newly formed entity that has really contributed greatly to the way we are able to structure and execute on clinical trials. She also serves as the medical director of the MFA GW Hospital Pulmonary Hypertension Program and has built a really terrific comprehensive management program that includes outpatient management, inpatient diagnosis and treatment, non-invasive and invasive testing, and state-of-the-art pulmonary hypertension treatment options. This program is now the only accredited pulmonary hypertension comprehensive care center in Washington, D.C. Dr. Gomberg-Maitland earned her bachelor's degree from Yale, completed her medical degree at Albert Einstein College of Medicine at Yeshiva University, with a special distinction for research in cardiovascular medicine. She completed her residency in internal medicine at New York Presbyterian Hospital, Weill Cornell, and was accepted, and then did her cardiovascular diseases at Mount Sinai Medical Center. She also, along the way, picked up a master's in clinical epidemiology from the Harvard School of Public Health. She's well known for her extensive portfolio of pulmonary hypertension research and heart failure, and has always had a translational and early targeted therapy approach to her research. She has a very strong background in clinical trials, hence her role here with us in the Office of Clinical Research, and she's contributed greatly to advancing methodologies and the understanding of pathophysiology of this and many other complex cardiovascular conditions. It was sort of nice. We had to have references for these proposals, and Dr. Bill Borden actually was kind enough to submit one, and his comments are notable. He said, "We're incredibly fortunate," and I echo these comments, to have one of the world's experts in pulmonary hypertension, Dr. Mardi Gomberg, and now with the arrival of Dr. Fagan, another renowned leader in pulmonary hypertension, GW will truly be a powerhouse in this arena. And if you look around the country, there's not a whole lot of those powerhouses that focus on this particular vexing condition. And so it's really great to have this footprint here. We'll be one of, I'm going to say 5 or so, 4 or 5, something like that. It's great. So I'm really glad that we're going to have a chance to hear from them today. I'm not going to go into begin to describing to you what pulmonary hypertension is. I just remember it as a surgeon as being a very difficult thing you didn't want your patients to have. But here, we're going to let Dr. Fagan and Gomberg present their lecture and inform us about all of those things. But before the talk, let's come up here and get our awards, take some pictures, and then I'm going to turn the podium over to the two of you. And I want to say, as we do that as well, I want to remember that at the end of this event, we have upstairs on the 7th floor in the Weingold Conference Room a lovely reception we hope you'll come and join us for. So with that, here we go. Okay.
Thank you very much. Yes. I can stand. Yes. Thank you again for that really kind and effusive, overly so introduction, but it's a real pleasure to be here, and I can tell you that my 6 months here at GW have been really tremendous. I'm incredibly pleased to be part of this organization. The quality of the clinicians, the rest of the staff, everyone's been just really terrific. So I'm going to start with the, I guess that's an attendance slide. And actually mention I have no relevant disclosures related to this talk. So what I'm going to tell you briefly is a story about collaboration, a little bit about the clinical and science and how we got to kind of some of the therapies we're at, and then Marty is going to take you through some of the real state-of-the-art clinical work that's being done to really improve the outcome of these patients, and a lot of the work that she's done in clinical trials to get to that, that distinction of finding really the best way to treat these patients. So I'm going to start with a story of collaboration, and we'll get to that in just a minute. But first and foremost, I wanted to talk about what is pulmonary hypertension. So normally the blood pressure within the lungs and the right side of the heart is quite low. When you look here, you can see that the pulmonary artery up in the upper left-hand corner normally has a systolic, or that top number pressure of 25 millimeters of mercury, and a mean pressure, an average pressure that's quite low. And you can see that the right atrium and the right ventricle, which feed blood into the pulmonary artery, are similarly low. If you look on the other side of the heart, the left side of the heart, you can see the aorta, which is in the top right. And again, that has a very high systolic pressure. That's similar to the pressure that's measured when you have your blood pressure measured in clinic. So that top number, 130 or whatever it is. And normally the pressures on the left side of the heart, particularly in the left ventricle, are higher than that to account for generating that pressure in the aorta. But the important thing is that notice that the mean pressure and the pulmonary artery pressure is significantly, many-fold lower than that of the left side of the heart. When someone has pulmonary hypertension, it really is a disease of the blood vessels of the lung, but its primary clinical impact is really on putting undue stress on the right side of the heart. So the right side of the heart was never designed to pump hard. It was designed to pump as a low-pressure pump. And when the pressure in the lungs goes up, and we'll talk about some of the reasons for that, then the right side of the heart is asked to do more work, and it can dilate, it can increase in its size, which actually makes it even less effective at pumping, but all the time while trying to maintain this need for a higher pressure to push the blood through the lungs, where the lungs have caused narrowing of the pulmonary vessels and therefore more resistance to blood flow. Now, the lungs are a really special organ. That's why I focus on them in my career. When you look at the blood flow through the lungs are the only organ that get actually even more than 100% of the entire output of the heart every minute. And that's important because normally the blood pressure in the lungs and the ability of the lung vasculature to dilate and accommodate all that flow is really important to making it work. And that's what distinguishes the circulation in the lungs apart from circulation in other parts of the body. So pulmonary hypertension, there's lots of ways that we clinically classify this, and there's 4 primary groups. Pulmonary arterial hypertension, which is what Marty and I focus a great deal on in our careers. And there's also pulmonary hypertension that can occur because the left side of the heart's not functioning well. Blood backs up through the lungs and causes dysfunction of the right side. Also pulmonary hypertension owing to chronic lung disease or hypoxemia. So if you have low oxygen in your lungs, it causes the blood vessels to narrow, and over time that can cause the right side of the heart to fail as well. Chronic thromboembolic pulmonary hypertension is a special problem where people have had multiple blood clots over time that have landed in the lungs and caused damage to the blood vessels and resulting in kind of very complex scar formation that doesn't go away with just blood thinners. And last but not least, because we have to have this, we have the unclear, miscellaneous, we don't understand how or why, but things happen there. And some funny things in there that can happen: sickle cell disease or other hemolytic anemias, chronic renal disease on hemodialysis, other types of diseases can fall into that category. But for this talk today, just like what we do mostly in clinic, is to look carefully at the patients who have this group 1 or pulmonary arterial hypertension. So one of the things, again, is that also we have to subcategorize everything because, you can't explain everything. So group 1 disease has these multiple categories. Idiopathic, meaning really out of the woods; heritable, with both known and unknown mutations; drugs and toxins induced; and then associated with other diseases. And some of our associated ones are actually the most common types of pulmonary hypertension. But again, idiopathic is still a big one. But importantly, I want to focus on the drugs and toxins briefly. Many of us remember fen-phen and Redux and all of those things in the late 90s, and they were taken off the market because of heart problems, but they were also associated with the development and, quite frankly, an epidemic of pulmonary hypertension. There had been a previous epidemic of pulmonary hypertension associated with Aminorex, which was a previous anorexogen used. Many years previously, we didn't learn our lesson, unfortunately, but now fen-phen, the fenfluramine component, and Redux, the dexfenfluramine, are off the market for good, thankfully. But there's an important chemical similar to those, which is methamphetamine. So if you look at the map of the United States there, you can see the areas with the blue, the pinkish, the green, and the orange, and those are kind of just big areas of our country. And it's hard to see here, but if you look at the western half of the United States with the blue, they're looking at very common meth use in those regions of the United States. And in some centers, 2/3 to greater than that numbers of patients presenting to their centers with PAH, that group 1, have methamphetamine-associated pulmonary hypertension. And that's growing. In the South, it's growing. In the Midwest, it's growing, but not as quickly. And on the East Coast, again, it's growing as meth use increases. So this is one of the real terrible epidemics of pulmonary hypertension occurring in our country that's absolutely related to methamphetamine use. And the patients have a poor outcome. On the bottom graph, if you look, the top dark line are patients with idiopathic pulmonary hypertension. And if you look at the bottom line, the dotted line, those are patients with methamphetamine-associated pulmonary arterial hypertension, and those are survival curves over time. And that's with treatment. So even with treatment, our patients with amphetamine-related PH are doing poorly. So who gets pulmonary hypertension besides meth users? Okay, so when you look at idiopathic, it really is a difficult understanding the prevalence and incidence, but we think that there's an incidence of 15 to 60 people per million people worldwide each year, which results in about 20 to 30,000 prevalent cases in the United States, although that number kind of changes depending upon what studies you look at. And so again, when you look at this, maybe 1,000 to 2,000 new diagnoses in the United States each year. We used to think that it was a disease of only young women, but we've realized now through careful registry studies that Marty will talk a little bit about, that really the population of patients has shifted into the 50s and 60s. Women still have more prevalent disease than men, about 1 to 3 women per every 1 male. And today, even with effective therapies, when I counsel a patient that I'm making this diagnosis with, I use the word life-shortening progressive illness. Stopped using the word terminal or fatal because it tends to shut down conversations. But our goal with our treatment is to make the impact on the life expectancy of these patients and the quality of their life the best that it can be. So overall, it has a poor prognosis when not treated. This is from the registry data that was published in 1991. There were 194 patients in the United States at the time who were identified and part of this registry that went on for over 5 years. When you look at the survival curve, and again, this is before we had any specific therapies, at about 2 years, less than half of the patients were still alive. So it's a disease that has a terrible prognosis without treatment. And we don't know that this has changed in the natural history, but we do know, and Marty will show some data to say that we've shifted this curve for patients with current therapies. So I said this was a story about collaboration, and I'm just going to highlight this timeline. So if you look on the way far left, that's 1200 AD, okay? And in there we have our first description of the pulmonary circulation in anatomy text. But another 300 or so years go by, and it's kind of rediscovered. And then in the 1700s, people began to look more carefully and catheterize animals and begin to look at different chambers of the heart and how they were affected and changed over time. But in that box that I highlighted, that's really the mid-90s up through today. And that, if you look then, the 2 big, tiny little boxes and the third one down on the bottom, those are all the advances that we've made in that very short period of time. With some exceptions, there's a Nobel Prize in there for some of the descriptions of stuff. But really, when you look at it, the progress that this disease has made, particularly with therapeutics, really starts in the 1990s and moves forward. So I'm going to talk a little bit about the disease. We don't know what causes it, but this was from an old friend of mine, a dear mentor. This is back for those of us who have been doing this a long time when you had to hand draw your figures for papers. There weren't computer ones. And so my dear mentor, Jack Reeves, put out an editorial, and he talked about this kind of notion of when we talk about the increase, how much of the increase in the resistance to blood flow, that PVR, how much of it was due to vasoconstriction or the blood vessel's desire to constrict as opposed to open up and dilate, versus how much of it was fixed obstruction because the blood vessel wall structure and within the blood vessels themselves had changed over time so that now they were just like stuck. And he proposed that in early disease, we may have some vasoconstrictive components, but as the disease progressed, we had more vascular remodeling. So one of the things that people began to look at is kind of developing pathways like this for the pathogenesis of the disease, where on the left-hand side, it starts with that vasoconstriction. What are we doing to keep the blood vessels from constricting? Why are they constricting? What can we do to open them? And then over time, added layers of other things, such as the smooth muscles there, looking at other inflammatory mediators, and then ultimately leading to the notion of vascular remodeling and that fixed obstructive remodeling. So I'm going to put an arrow in, and that's where I got excited about pH, was in this era of pH work. And it became because of patients. I had the chance as a fellow to round with my pH mentor, my clinical mentor, and really became enamored with the patients and their problems. They were really incredibly courageous people who were willing to do a lot to try and improve their outcomes, but also the science and the physiology just was really intriguing to me. And so I began my research intensive component to my fellowship in the laboratory studying pulmonary hypertension. And I got known as the mouse lady from Denver. And so this is in the mid-90s, and this is when a lot of transgenic mice were now becoming available for research. And for many years, we'd been able to measure cardiac pressures in rats using catheters, just like we do in the cath lab now. But we didn't have catheters with the fidelity and the size to allow us to look at pressures in mice. And so we used surrogate markers like whether or not the heart was enlarged, kind of things like that to suggest the presence of high blood pressures in the lungs. Well, one day I was in the lab and I was doing a cardiac puncture on a mouse, and I said, you know what, let's hook up a pressure transducer to this and just see what we see. And I was able to develop a method by which we could measure left ventricular pressures on the left side of that screen and right ventricular pressures in mice. And really this set forward a whole bunch of research in our own group, but also the mouse lady from Denver, the person who said this is a dear friend now at Brown. And this technique got used to advance a lot of studies, and I was proud to be known as the mouse lady from Denver. But one of the things that we did in our lab is we focused on vasodilator therapy, and we had known a lot about the top 3 pathways of vasodilators before we started this work, but we now had the chance to really ask a lot of questions using these transgenic and knockout mice. And so nitric oxide pathway was one of the targets of trying to understand because it vasodilates the pulmonary circulation. And we knew that in patients there was relative decrease in the activity related to nitric oxide in their lungs. So what we did was we then said, okay, well, what about knockout mice for this? And we found that knockout mice were extra sensitive to the challenge of hypoxia. And so we were able to demonstrate the fundamental, at least, role of different types of knockouts of the nitric oxide synthase enzyme, pardon me. We then looked at prostacyclin. We know that prostacyclin was decreased in patients with pulmonary hypertension, so we used transgenic mice or mice overexpressing prostacyclin and demonstrated that they were protected. So again, confirming that these pathways, were really relevant in these diseases. And then lastly, but not least, endothelin, which is a protein we all make in our endothelial cells. It's increased in patients with pulmonary hypertension. However, this one we showed that transgenic mice that do not develop an exaggerated pulmonary hypertension. So while we had clinical data and other things to suggest that this vasoconstrictor pathway may be involved, at least in the transgenic mice and other studies that we did, we couldn't really say that it had as much of a fundamental role as some of the other ones seem to have. Now, one of the problems, these were all models of pulmonary hypertension that were just based on hypoxia. So it's not really the same as the true disease in patients, and we'll get to that in a second. I just added to the bottom here rho kinase. Rho kinase is a calcium sensitizer. It's been increased in patients with pulmonary hypertension. And one of the things that we were able to show is that rho kinase is a really potent vasodilator of the pulmonary circulation. I only put that in there because this is a pathway that we worked on, 20 years ago and is finally coming to clinical trials as a therapeutic option in the United States. It's been therapeutic trials elsewhere, but I just put that up there because our group was just 100% all over this, every meeting you could go to, and we just couldn't get a company to invest in it. So anyway, these are our current therapies that we have that again focus on those three primary vasodilator pathways. So again, the endothelin pathway on the left, you can see that we have endothelin receptor antagonists. So endothelin's increased, we use medications to block the receptors for that protein. Nitric oxide pathway, it's a little more complicated, but what we are targeting is the messenger that we see that's in nitric oxide signaling, the cyclic GMP, and ways to either improve the production of cyclic GMP in the cells or diminish the degradation of cyclic GMP, and that leads to vasodilation. And then in the prostacyclin pathway, we know it's decreased in patients with pulmonary hypertension. For many years, we just had a replacement strategy where we would just give people excess prostacyclin with the hopes that it would overcome some of the signaling abnormalities associated with the decrease. And more recently, we actually now have a medication targeting the receptor for prostacyclin. So again, these are our current pathways. These are our major drugs. We have multiple variations in these drugs, but these are the ones that we have. So again, we're not addressing that vascular remodeling component. And again, as my dear friend Jack, I of course modernized this, but said, look, we're diagnosing people generally late in their disease when they're not very vasoreactive anymore. But what we're doing is treating them with vasodilators. We need to really think about that vascular remodeling and focusing on that as the ultimate in therapeutics for these patients. So again, in looking at this, you see that there's those are different pictures of the vascular remodeling that you see. Normally a blood vessel in the lung is wide open, very thin-walled, and you can see that these are plugged up with cells. They're very deranged in their appearance. And one of the problems that we had was that we didn't have a great animal model. I told you about the fact that we had hypoxia, and other people had looked at models that more closely looked at the neointimal or the pathology we saw in humans, but a lot of them were really difficult. We're talking about using primates and piglets and other larger animals. That's not a bad idea, but they're very difficult to do. One of them up there is something that our group worked on in Colorado, and what we developed was the Sugen hypoxic rat model. And so again, there's the same human panel on the side, and you can see in our rat model that we described for the first time in 2010 that it has more of those vascular lesions more akin to what we would see in humans. So Sugen is a VEGF inhibitor, a vascular endothelial growth factor inhibitor. When you combine it with a pattern of hypoxia and then reoxygenation, you can see these. And the mice get right ventricular failure. They get all of the cardinal features of that. And so I was really proud that our group published this in 2010. And as you'll hear from Marty, this is still the model of pulmonary hypertension used across the world for the study of this disease. So again, I said this was a collaborative study. So here's where it gets really collaborative. So these 4 women are a group of women who either have PH or a family member with PH. They met each other for a luncheon in 1991, and they met each other through waiting rooms of the few specialists in the country that were treating this disease. And they came together and had lunch, and at that point in time, they decided to found what's called the Pulmonary Hypertension Association now. And so again, they got together, they had their first patient support group meeting where they contacted patients, many of whom they met through the registry that we described earlier. In 1991, they had the first patient group meeting, and in 1992, they declared themselves a nonprofit. In 1992, they also, and these are lay people, they formed what's now known as the Scientific Leadership Council. They knew that they needed to have scientists and clinicians engaged in order to come to the table to bring forth the best treatments and ultimately a cure. In 1992, they actually developed a list of treating physicians from across the country and began to share that with people so that patients could find people who had some experience with this disease. And in 1994, They hosted their first international conference. And at this conference, they brought together patients and their families, researchers, and those clinicians that they had engaged with. And these women had the presence of mind, along with advice from the Scientific Leadership Council, to have established at this meeting a research room. And that research room has been a highlight of every international conference ever since. And this was an opportunity for people to collect blood and clinical histories from patients who are all gathered in one location. One of our friends who was instrumental in identifying the gene, the chromosomal locus of this, said that he would never have ever been able to gather as many patient samples in 20 years as he did in 2 afternoons at Stone Mountain, Georgia, for this first meeting. Again, they've continued to grow in their collaboration. They established a research program where they fund primarily junior investigators. They collaborate with other organizations, including the NIH, to provide supplements, like to a K award and things like that. They've also established the first journal specifically focused on pulmonary hypertension. They added scientific sessions to the annual conference. And so part of the first day is designed for researchers and clinicians to go over the latest, most state-of-the-art science. And then in 2005, they started an international summit because they wanted to populate the world with PH associations, because PH is not a disease of only North America and Europe. In 2014, they launched the first PH accreditation programs, and I'm very proud that Marty got the GW Comprehensive Care Center accredited through the PHA earlier in 2024. And now in 2016, they also launched the PH Registry, which has been an incredibly powerful research tool. And again, it started with these women and the dog under the table, and has really led to incredible accomplishments. So one of the most important things that they did was, through the work that was put together at the international conferences and through some of the samples taken in the research room, the most common gene mutation or gene that is mutated in pulmonary hypertension was identified as a direct result of this collaboration between the patient community, the clinicians, and the researchers. So in 1996, it was the chromosomal location of this PH gene was identified. And then in the summer of 2000, 2 groups who were working independent of one another identified the bone morphogenetic protein receptor 2, which is a TGF-beta receptor, as the most common gene mutated in PH. Unfortunately, though, there's not a single mutation. And that's been one of the problems that we've had, is that there's mutations throughout the gene. And so the signaling abnormalities can vary family to family, but clearly this pathway is vitally important. And one of the things that has really been important is that through similar work, we've identified many other genes that are associated with various forms of pulmonary arterial hypertension. But really, it comes down to defects in the signaling related to this pathway, the bone morphogenetic protein receptor 2, are abnormal in almost every group 1 pulmonary arterial hypertension patient that you can find. There's nuances and difference between them, but this pathway is clearly fundamental. And so that has led to the first molecular targeted therapy for pulmonary hypertension that was just approved last year by the Food and Drug Administration, and that's called sotatercept. And again, the goal of this therapy was to be able to use it to restore some of the normal signaling properties associated with the morphogenetic protein receptor 2. I can show you this really nice slide, but basically it takes, and the drug inhibits the ligand binding for some of the proteins that are out of balance when the BMPR2 mutation is present. And so it kind of restores that normal balance of signaling. And that importantly is important in proliferation, that growth of cells, that abnormal structure. So this is our first non-vasodilator therapy. It's molecularly targeted to the gene dysfunction or the protein dysfunction that we see in most patients with pulmonary hypertension. And it is a direct result of collaboration between the patient community, researchers, and clinicians. So this is just some of the data from that trial. You don't need to see it, but it was incredibly powerful, the game changer. And I think for most of our patients who are on therapy with this, we can already say in the first 6 to 8 months that it's been a game changer. But again, when you look at some of the targeted therapies across the spectrum, I just highlighted these 2 pathways, but there's so many other theoretical pathways that people have looked at over time in pulmonary hypertension. And there's even more complicated schemes for all of these potential pathways. But again, really the story is from the mid-90s to now, we now have 16 FDA-approved therapies. I think that's the right number. And more or less 1 molecular target that's a game changer for these patients, and all of it came between collaborations, again, the patient community, the research community, and the scientific community, and the clinical community. So now I'm going to turn it over to Marty, who's going to talk about really state-of-the-art clinical evaluation and assessment of patients to help identify that next game changer therapy. Thank you. I'll take your crutches. Are you okay there?
I don't have the same height as Karen, so I'm just gonna. Okay, so these are my disclosures. As Dean Bass stated, I've been involved in drug development pretty much since I finished cardiology fellowship or even during fellowship. And so I'm a consultant for multiple pulmonary arterial hypertension companies and left heart disease to really try to design trials and develop drugs. We also do a bunch of research here at GW, and my husband is actually an employee of Pathos, and the company is in cancer therapeutics. So what Karen has clearly stated is that over the last really 2 decades, we've transformed the disease prognosis from a rapid death sentence to a manageable chronic condition. And I say that sternly because that's really the truth of it. Where did we start? This was a clinician, my former colleague, partner, Stu Rich, in the cath lab. You can see 1978 are the dark lines, elevated pressure, it's almost 60, a normal cardiac output with an elevated resistance. And then they did vasodilatory testing, and you can see that you get improvement in pressure and output and a drop in the resistance in the blood vessel. But just in 2 years, it's really gone, and the pressure gets higher and the heart gets weaker. And so they then published this NIH registry, and I made it nice and clear for you guys. 1 year survival was 68%, 2 years 48, 3 years 34. This was like a cancer of the lungs. And it really surprised folks on how dramatic that was without therapies. So how did we get to where we're going? So what you can see here is an echo. The top chamber is the right side. The bottom chamber that's underfilled is the left side or the left ventricle. And you can see the right ventricle is supposed to be 1/3 the size of the left ventricle, and it's really reversed. And you can see here it's really not moving. It's kind of just doing this. And the right atrium is extremely enlarged. And this is a severe pulmonary vascular disease. And so what we realized is that, it's a rare disease. We need to establish registries to then figure out what's going on. And that's when drug development skyrocketed. So this is a timeline. It has my training, which is New York, then to Chicago, to DC, and sort of the timeline that Karen showed of the different drug development. Here, getting here in DC, at GW in 2019, we have all these drugs. And what I did was I put little smiley faces for the trials that I was active in leadership in the drug development so that you could get a sense of like how long I've been doing this and what I've been involved in. And then the little stars are for trials that patients either participated in or before my time or after my time, like while I was seeing these patients, to just get a sense of how patients really are integral to this and how much the patients, if I'm taking care of them in 2003 and they were in the 1990s on epoprostenol, this was a big deal. This is another way to depict the different targets and groups of drug approval, so you could get a nice timeline of conventional therapy, prostanoid, ERAs, PDE5, all the stuff that Karen discussed, and then the active ligand inhibitor, which is a trap and it's really the only drug that's targeting proliferation. So I thought I'd just give you a very quick overview of the drugs. So this was our first drug approved, epoprostenol. Robin Barst published this paper in 1996 and showed that the patients that got the drug in this short 12-week period in the ICU did not die, and there were deaths when what I heard from folks that were participating is they were just waiting for the patients to roll over and hope that they made it because it was such a huge difference. But what you can see is we really brought the ICU home to the patient. It was just not an easy therapy. It required it to be cold all the time. This is the list of things that they needed to do. They needed to mix it. So it wasn't perfect, but it was life-saving. We still use it here in the hospital in really sick patients in shock and in really high-risk patients. But we needed to do better. This slide shows prostacyclins and how that's evolved. We now have treprostinil, which has a longer half-life. I forgot to mention that epoprostenol half-life is 2 minutes, so if that pump stops, it was life-threatening, often fatal. This is a 4.5 hour. So, we made improvements in the drug development where treprostinil is now subcutaneous, intravenous, inhaled, and oral. What about the other oral agents? This is, endothelin receptor antagonists are on the left. Some were twice a day, some were once a day. We actually realized that selective versus non-selective didn't make a clinical difference. PDE5 inhibitors, we were really happy that sildenafil and PDE5 is expressed in the lungs because we all know sildenafil and Viagra was not supposed to be for pulmonary hypertension, so that was a real nice repurposing. Tadalafil, riociguat is a guanylate cyclase stimulator, and selexipag is that receptor agonist that Karen was talking about. So I like this slide because it shows us the pressures and the pressures in the trials and the change in the pressure with therapy. So you can see epoprostenol, the average pressure went from 55 to 50. And you can see across the board, these were all the monotherapy trials where it was just the drug versus placebo. And there's really small changes in the actual pressure. If this was in systemic hypertension, you'd think this was a failure if it only dropped 3 to 4 millimeters. So we said, well, what's actually happening? Well, patients were doing better and feeling better, and we saw that the right ventricle was doing better, but it was nowhere near goal. This was a case report that we published 2010. It was a patient who was in the early epoprostenol study in 1993. She was doing great. We added sildenafil. She was functional class. She's doing amazing. She's working. She got colon cancer. Her right ventricle was only mildly dilated and dysfunctional, but you can see on autopsy this severe vasculopathy. So we said, you know what? We're vasodilating, but we're clearly not targeting the vasculopathy. And just in comparison, the drug that Karen discussed, sotatercept, it's the first time that we've seen a mean PA pressure that's dropping more than 10, if not 15, sometimes even 30 millimeters of mercury in 6 months. So we are actually now able to target the proliferation. And so this was the New England Journal paper that came out now almost 2 years ago that led to that drug approval, which, this is a big game changer because we finally have made some progress on the actual pressure and the vasculopathy. And again, Karen showed this, but this was the 6-minute walk distance, which was the primary endpoint. But what's more remarkable is that 8 of the 9 secondary endpoints were met. That's what it's supposed to be. If something's working, it should work in all of our secondary endpoints. And it was really nice to see and why we're starting to use this more often. So I thought we should start from the beginning. So registries, because without registries, we would have no drug development. We wouldn't really understand the disease in an orphan disease. This was our registry. We called it the Pulmonary Hypertension Connection because it was patients and physicians and scientists. And it was the first time that we could actually compare pressures, exercise tolerance, echoes across the group PAH. So you can see it's idiopathic congenital heart disease and really try to learn from our registry. But what we found is it didn't matter where you were in the world, we found similar results. So the REVEAL registry was 52 sites, US and Canada, versus ours, versus French, versus Chinese. Really, patients were coming to us late, really sick, and had very elevated pressures. From then, we decided we really want to know what the prognosis is and the survival. And like the NIH registry in 1991, we each created survival equations. The bulk of them were from the hemodynamics, because when we put other factors in, they actually fell out. And what we showed is that our registry equations were much better than the NIH registry equation, which you can see on the left-hand side in predicting survival. But it was good for cohorts in clinical trials. But when the individual patient, all of our equations, it was just like flipping a coin. It was, our ROC curves are 0.5. It really was not great for the individual patient. So we realized that we really need to understand who's at high risk and how can we personalize from our registries these risk factors. So our pulmonary hypertension connection, amongst others with large registries, we found lots of risk factors. I think the most significant one is the serum creatinine, which is held up irrespective, and I think nobody wants to admit it, but clearly this is a risk at baseline, and these are all at baseline predictors. We found that RV ejection fraction MRI wasn't just a predictor of survival, but it was actually a predictor of hard endpoint of clinical worsening, decompensated heart failure, hospitalization, lung transplant, and even by itself. You didn't need the exercise capacity, but again, the pressures are still the key. And this led to risk calculators. Now, I'm not going to go over all of these risk factors, but what you need to know is, one, there's an app to calculate this, and two, it doesn't really matter what risk calculator. You know, as a cardiologist, my goal was, wait, we have a TIMI risk score. Why don't we have a risk score in pulmonary hypertension? Because we need to know how we should be treating our patients, and we need to understand a little bit more than just gestalt. We also have recently added imaging to our risk equations, and I think that it really makes a difference because, right, they're dying from right heart failure, so we need to have imaging. So what's next? We are working on machine learning for these risk calculators, and this is showing you all the variables in that reveal US equation, and then you are able to see what's contributing to it for the individual patient in their risk assessment. So we're moving along. And then finally, with risk, in now all of our guidelines, we use a risk assessment as part of our normal clinical practice to determine how we should escalate or just stay the same with current therapeutics. So risk has become a big deal. Moving on to imaging, which I think is the wave of the future, because we can't really lung biopsy these patients. These patients are really sick. They're not going to tolerate a lung biopsy, but we really want to know what's going on at the vascular level. So this is an imaging slide. It's a new technology with an old test. So this is just an infused CT with different breathing protocols that the company developed an algorithm to be able to look at the small vessels. And you can see, you can look all the way up out into like less than 5 millimeters of the surface area. So we're able to see those small vessels. And I like this slide because I think it's really cool. You can see the healthy lungs. This is what it generates versus the PAH lungs. And you can see all the pruning, the vasoconstriction on the periphery. And okay, so now we have this imaging, but how are we going to use this in clinical trials? Well, we have to include them in clinical trials. So this is seralutinib, which is a tyrosine kinase inhibitor. And this was the phase 2 study where they had a sub-study. And you can see clearly here from baseline to week 24, and the placebo patient, there was no change in any of the ratios between the sizes of the vessels and the amount of the vessels that were affected versus the patient that received drug. And you can see up on the top that all of a sudden now you see vessels in the periphery. So we can do better than just looking at a 6-minute walk test. We really need to be looking at the vasculature, especially now that we're using antiproliferative agents. And then, you know, Karen said we've been focusing on PAH. You know, she's a pulmonologist. She also looks at PH-ILD and lung diseases. And as a cardiologist, the most common cause of pulmonary hypertension is actually left heart disease. And this technology allows us to differentiate between the arterioles and the venules. And so I think that that's really what we need to be doing when we're actually looking at high pressure in the lungs from left heart disease. So now this is really neat. My former fellow, who's now at Northwestern, who I did an early MRI study with, is looking at four-dimensional flow. Andrew Bradley and I read a paper just differentiating between what's pulmonary arterial hypertension and PH left heart disease, which you'll see on the next slide. But this is normal 4D flow, looking at the velocities through the pulmonary circulation. This, the top one, is pulmonary arterial hypertension. And if you look at it closely, and you can see the MRI next to it with the RV and the LV, and it's pumping, and you can see the blood moving from the atrium to the ventricle. But you see the orange in the middle, that's called a vortex. Like the vortex velocity is really high, and it's because the resistance is high, you're actually getting a shelf on the posterior wall to create that. Compared to left heart disease, where you have elevated resistance, you can see it's really only at the beginning of the main PA that you see the orange. And so this clinically is really difficult often to determine the difference between PAH and PH left heart disease. And it's telling us, again, imaging is the wave of the future, that we might be able to do this without doing the heart catheterization. And it's going to really help us with therapeutics. So in my last minutes of this, I want to talk about team science. So this is, I think, the way that we need to go about this at GW. And I'm going to show you a couple examples from Chicago. So I've done one mouse study in my life. I don't have the patience for the lab. I'm a clinical epidemiologist, drug development. But my husband is a phase 1 cancer doc, and I spent time with the phase 1 group at University of Chicago. And the reason why this could work was because we had a really strong phase 1 group, and they actually developed this drug sorafenib for renal cell cancer. We had strong pulmonary vascular basic scientists. Our chair of medicine was a pulmonary vascular disease basic scientist. You had me, who was interested in the clinical trials, and you had a community of patients. And we did this animal study. We did the model that Karen's group created, the SU5416 hypoxia model. And what we did was we looked at the safety control groups, and then we did hypoxia sorafenib, and then we did the SU5416. And what we were able to show was that sorafenib, which is a VEGF receptor inhibitor and RAF kinase, so multi-kinase, tyrosine kinase inhibitor, was able to prevent pulmonary vascular disease from happening in the rats. And our colleagues in Germany showed that it was actually able to reverse it. So then we said, okay, next step. And what we did was we applied for a Doris Duke grant, which I got, which allowed me to do the phase 1 study. And this was a individual dose escalation study. But you know what? We titrated to the cancer dose, which was 800 milligrams. But you know what? That was not the right dose. We actually, the majority of the patients ended up on 200 milligrams, if not 400 milligrams. And we saw preliminary efficacy. You can see here that the echoes, the RVEF in 3 dimensions improved. We had improvements in exercise capacity. And then what happens with repurposing drugs is that sometimes things happen we don't expect. We actually got improvement in the rash that patients hated on epoprostenol. We didn't predict that. But this was, again, another way we could collaborate. So we had a dermatologist who was at Northwestern who we knew from Sloan Kettering. You know, everybody knows somebody. And he studied it, and he found that all of a sudden, now that we were not having vasodilatation from the prostacyclin, we didn't have the rash because of the VEGF inhibitor in the skin, because it was a systemic reaction, not just in the lungs. So at the same time, imatinib was being pursued, and Karen was involved with the imatinib study. She was actually on the DSMB, and it was very unfortunate because we didn't take our knowledge from cancer and all of the data on imatinib, which is, as most of you know, approved for CML. BCR-ABL and c-KIT are pathways that are affected in pulmonary vascular disease. We had a bunch of case studies. We went to phase 2, we went to phase 3, and unfortunately, we had bleeding in the head. Bleeding in the head is never good. We had 8 of those. We weren't sure if it was from the drug, but all these patients were on warfarin, and it just didn't make it to phase 3. But this group, which is in press, this article that I was lucky enough to review was showing us that we can do things better. So they actually did a smarter, small study and found that the dose was actually 200. Before, it was 400, and that's why also half the patients didn't, less than half the patients tolerated the drug at the cancer dose. So they basically did exactly what we did and said, we can't do this dose in these patients on our background therapies. And then many of these patients, and it was during COVID, had internal monitors. And I think that an internal, cardiomems, hemodynamics really gives you nice data showing the improvement in the pressure, which is at the top, showing the improvement in your heart rate at night, and showing your improvement in activity, that when they withdrew the drug, everything started to come back up. So you could see that it was making an effect. And then finally, the other way that we did team science was, as a clinician, drugs are approved at a dose that's not often the dose that we use in practice. So treprostinil was approved, the original study, the patients were on 23 nanograms. But what you can see here on the bottom, when we started patients on IV treprostinil in this nice little 5-centered study, we got up to a dose of 98 nanograms because we didn't really know anything about dosing. And then when we looked and we did a multivariate analysis of all of our trials, the higher dose you had, the better the survival. So I teamed up with my colleague at Allegheny, and we put in this pharmacogenomics grant and said, okay, so why do some people need higher doses to get the hemodynamics that they're getting versus lower doses? There must be something. It's 100 patients. We were really surprised to find anything. We had 3 loci that in that Manhattan plot that almost met statistical significance. And what we did was we pursued the CAM-K2D because there was already biologic evidence that this affects the heart. We know that overexpression causes failing of the RV and the LV, so right and left ventricle, and that if you actually inhibit it, you can get restoration of the contractility. And I don't have time to show you that we did do more animal studies at Chicago to show this. We also looked at our SNP in a big data set that's available, big international genetics data set, and showed the same thing. And then we looked at it in our cath data and found that the patients that had the allele, so had the SNP, had higher RV pressures. So it put a nice story together. And the next step is, do we do testing, or how do we use this SNP to try to better target therapies for our individual patients? So I'm going to end with this really pretty picture that came from the World Symposium, which really shows that it's not just clinical science and it's not just basic science, it's really the integration of all of it. And, we're at the genomics, transcriptomics, it all sounds very fancy, but we're there. We are there to personalize, and we can do this here at GW. I also think we can form teams to really study the right ventricle and make the right ventricle to study and make it great again. We need to engage the community. We have a large community that really needs to be engaged. And team science, this is really the way of the future. And then I forgot the clinical care, we have that already. So with that, I want to pass this over to one of my dear patients, Beth, who's going to just give us an overview of her disease, how she was diagnosed. She's been one of those patients who's done extremely well, participated in clinical trials, and it's not an easy thing to be a patient, even with all of these therapies, but it really takes a team and her family, which she's going to tell us about.
Thanks, Dr. Gomberg, and thank you all for being here. I am really excited to share this anniversary, 200 years. That's pretty amazing. And it's really an honor to be part of this. The whole idea of collaboration has really come to mean a lot for me over the last 7 years. September 29th, 2017, I was diagnosed with IPAH. What a shock. had no clue what that was, had never heard of pulmonary hypertension. And seemingly it came out of the blue for me. I was I worked full time, I was pretty active. Looking back, there were symptoms that did point to what this disease is all about, but they're very vague, especially when it's not severe disease. Shortness of breath, leaning over, some heart palpitations. And I had talked to my own PCP about this. We did an EKG 6 months before this was diagnosed. Because of the vagueness, it's very not unusual that diagnosis takes a very long time. Then we were visiting my daughter in Montana, and I really credit the ER staff and the cardiologist in a small hospital in Missoula for paying attention. And within a weekend, I went into crisis, and they diagnosed me, confirmed it with both a right and a left heart cath, idiopathic pulmonary arterial hypertension. And I think they really put me on the path to saving my life. So that was an amazing thing. When I got back here, by the way, they didn't want me to get on a plane. They wanted me to start treatment there. And I was like, I'm going back home. I live in Northern Virginia. This is good care. And my primary care physician had another patient with PH. She was flabbergasted at my diagnosis, but knew where to send me. So I immediately got referred to Dr. Gomberg at the time at Inova Heart and Vascular. And she asked me to tell you how I got mentally prepared for IV treatment. So my family's here to support me. I'll talk more about them, and it's not funny. When I first met Dr. Gomberg and her team, I was immediately impressed that she engaged me, my husband, and our daughters via phone on the clinical particulars of this disease, but also the context of what it was going to mean for me, what it was going to mean for our family, and talked a lot about how she and that team could be supportive services for all of us. And so right away, the first time I met her, even though I was feeling awful, I had a sense of okay, these people know what they're doing. And there was a trust developing. She described different treatment options, one of them being IV Remodulin, which is the treprostinil, and felt that I was in a severe enough place that that was the way to go. And I was having none of it. I was not interested. I was afraid. At the time, I was a hospice chaplain, and frankly, I think I knew enough to be scared. I had seen end-stage sepsis, for example. I don't want a hole in my body, thank you. And to her credit, Dr. Gomberg gave me the grace of 2 or 3 weeks of saying, we will start you on ambrisentan, and you will come back, we'll check the numbers again and see how it goes. So I was also on Lasix and metoprolol at that point. So we did that and came back in 2 to 3 weeks, and the numbers hadn't budged. I was absolutely no better, still feeling probably the worst I've ever felt in my life. And by then, my family was on board, and they were saying, we have to do this. It's funny, I think they had a better handle on how sick I was than I did. Just as an example, I didn't get it that I was in severe heart failure until months later. I never heard that. It didn't compute. So reluctantly, I said, okay. And to their credit, the team did exactly what they said. In mid-December, a PICC line was placed and the drug was started. And then by the end of December, maybe beginning of January of that year, I had the IV placed. I got my favorite little utensil This is one of my spare pumps. We put a cassette on it, and I wear this around my waist, and the tubing comes up and then is delivered directly to my heart. The team there taught me the care and feeding of this thing, how to manage the side effects. Side effects kicked me, let me tell you. And then also how to take care of myself to stay as healthy as I could. It still took probably until May until I began to feel more like myself. But I honestly feel that this drug, more than any of the others, really did give me my life back. And that's when I began to feel, okay, this might work. Still not crazy about it. What was really neat then is I have known about the clinical trials. I think it's in the news, and I'd been in healthcare, but I never really thought about, is this relevant to me? So the summer of 2018, I was given the opportunity to be part of a clinical trial. Literally, somebody said, hey, we've got this trial. We think that you'd be appropriate for it. Here's what it's about. And I said yes. It was easy. In my case, it was convenient. It's really great living in the Northern Virginia, DC area, isn't it? There's so much going on. But really importantly, it was a chance for me to give back. It was a chance for meaning. I had felt disabled for the last 7, 8 months. I was on the couch with my feet up, had to quit my job. And this was a chance for me to say I can help somebody else if they find things out with what I do. So I was part of a clinical trial looking at rapamune or sirolimus and its anti-inflammatory properties. And it was positive for me. I'm still on it. So that was really pretty wonderful. And then the last thing I want to talk to you about, I am on that sotatercept drug that was just talked about, brand name Winrevair. It is something that we in the PH patient community feel like might be literally giving us a whole new approach and a whole new possibility of what could be going on. We already have some positive results. I had a great 6-minute walk last month. We'll be doing an echo next month. Side effects. At one point through this journey, I said to my family, so the side effects are really now worse than my disease. I think that's progress. And we keep tweaking because the side effects are there, but we find a way to make them manageable. And then, as I said, you get your life back and you're able to stand up here. I don't have to gasp for breath while I'm talking to you. And it's a far cry from where I was 7 years ago. I love the name of this talk, High Hopes and High Pressures, because I think almost from day one, I really was hopeful. And a lot of it had to do with the way the medical staff and the nursing staff, who are great. By the way, you notice I came to GW following Dr. Gomberg, I want to point that out, engaged us as a family and offered the support, the knowledge, the information, and even pointed us to directions that we need in order to make this crummy disease, fascinating but crummy disease, work for us. So again, thank you so very much for having me here tonight.
Well, that was terrific. I think really, from human collaboration to discovery, translational science, and then, of course, to the real impact that is the reason we do all of these things is for people like you. So thank you for coming and telling your story and being with us. So questions, comments, anyone? Do we have anybody in the office? Yes, sir.
You mentioned that creatinine You mentioned that creatinine correlates with prognosis. Has anybody looked at the kidneys to see if there's remodeling of the vasculature there, similar to the lungs?
Yeah, so I've asked nephrologists a lot of why small changes in GFR predict prognosis and why it's not like left heart disease, where clearly when they are in severe failure that their renal function goes to diminishes completely, right? It's dramatic. Whereas here it's even just small little changes like the GFR is 45 instead of 60, and it makes a huge impact. Nobody's looked, and I'm sure we have published that pulmonary hypertension is a systemic disease, and it's probably not just in the lungs, and it's everywhere. We saw that with our phase 1. You know, everything received some component of cardiac output, and it just seems like the kidneys, on the venous side, is behaving different with right heart versus left heart.
Other questions? Yes.
Is there any research being done on the mitochondrial dysfunction that's prevalent?
There's a tremendous amount of research going on in terms of metabolomics and mitochondrial dysfunction, particularly in the right ventricle. We clearly know that there is a Warburg effect that happens with metabolism. We know that mitochondrial dysfunction and mitochondrial-induced damage, proteins, DAMPs, things like that are all important in the right ventricle. And a lot of studies are now looking at ways to protect the right ventricle and the myocardial dysfunction associated. So there's, lots of different approaches. One of the simple ones is just metformin, a few other things that are looking at how to change the metabolomics of the right ventricle and its energy utilization through the mitochondria. But it's a big component of what we know about the heart. Less is known in the actual pulmonary blood vessels. I think that a lot of the focus has been now on really the structural abnormalities, and could there be, biochemical metabolism defects in those vessels that promote the growth of those very bizarre looking lesions? Sure, but right now the focus mostly has been on the energy needs of the right ventricle in order to maintain its function.
Well, I'm going to ask probably a question that reveals how little I understand about this, but I was fascinated by that beautiful picture of the rotating 3D reconstructed CT and the pruning and then the loss of pruning. And I guess my question there is, what is that reperfusion? Is that a perfusion thing? Do you actually have change? What are the structural changes that go with that? Or how much of that is just physiology? How much of that is just, okay, those blood vessels are open again and you can see flow out to the edge of them? How much of it is actual structural? Is there actually pruning of vessels and regrowth? Is there change in the coatings of the vessels? It's structural. What is that when you see those changes?
You can start.
I think it's both. Yeah, all of the above. I think that it's probably more vessels. It's not just constricted. I think that it's really vasculopathy and hyperproliferation and everything that goes along with it. Right? We see that. It's on. Yeah, we see that in our animal models, and we only have pathologic evidence. Right? We're not doing biopsies throughout the whole thing, and so that. All of our early grants, when we were looking at autopsy assessments, I thought this is really not what we need to do. We need to be looking at serial blood and plasma and now imaging to really understand what's happening and how we can prevent it.
Fascinating. Great. Well, I think we've, do we have one more over here? Hey, Dr. Norris.
Hello. First, I wanted to thank our lecturers, and I want to specifically thank our patient and the family that literally is the best story I heard all day. So thanks so very much for sharing. I have one question for our panelists. I understand that there's been mixed results with use of selective serotonin reuptake inhibitors in the treatment for pulmonary hypertension as well as like methamphetamine. And use pulmonary
Epidemiologically, there's not a clear tie between the clinical use of SSRIs for depression and things like that with pulmonary arterial hypertension. I think that many of us, early on, one of the hypotheses was the serotonin hypothesis, because again of the Amenorhex in the 1950s and 60s, and then fen-phen and Redux, again, because that's, a prominent component of that signaling, that the serotonin hypothesis was really top of mind. And so people really tried to look at whether or not there's any association type of evidence. And really, to date, there's not been any clinically conclusive things. I can tell you my personal practice, and again, this is not based on any evidence, is I try and limit the exposure to other serotonergic pathway drugs in the odd chance that there's just something we haven't figured out yet. But that's my non-evidence-based clinical practice.
So I was going to say that we looked at our registry and didn't find a clear association with it, and it's been mixed in all the different registries, but we actually just completed a trial of a serotonin phase 2 agent that we had to stop because it caused harm. We had liver abnormalities, and the reason why we pursued it was because it wasn't going to cross the blood-brain barrier, and so they thought maybe then we would have some benefit. So I'm hoping that this isn't something that we're going to keep pursuing, because I think we've proved it a few times now that it's not perfect. There's a small trial looking at H2 blockers, famotidine, that's going to come out in, I'm trying to remember
Now,
what journal it was.
I think it's out.
Did it just come out?
It just came out.
Which was done well, but again, now I think it's also, even if it did do something, it didn't show anything.
Right.
And it's a small study, but you really have to be a blockbuster, right? I mean, our drugs are working, and so now to show added benefit, it really needs to change the pathophysiology. So I think serotonin's out.
I think the one thing that I'll mention about the H2 blocker study is it was done in Seattle and surrounding areas, where the vast majority of patients in the study were actually methamphetamine users. And whether or not that impacted the overall outcome, but what was really identified is that with a carefully, with a clinical team and a research clinical team, that of population of patients that we would automatically assume would not be good to study because of reliability issues and things like that, the principal investigator was able to demonstrate that methamphetamine users, again, with lots of support, are very appropriate to enroll in clinical trials. And I think that took a little bias that the community had had for a while about the methamphetamine patients again, but he demonstrated that, again, it took effort, but it was possible.
And it showed the importance of publishing negative studies, because they're not really
Absolutely.
negative. We're always learning from them. And so that methamphetamine piece actually is going to be really helpful for the design of all of our other studies. We saw that initially with HIV, that they weren't enrolled in our PAH studies, especially now with negative, undetectable viral loads. There's no reason why they shouldn't be included. And so I think that with every study, we need to really learn.
Well, I want to thank you for this fabulous talk. It couldn't have been a better one to wrap up our bicentennial time. And it really does give us great hope for the future when you think that all of this, the tools of modern science, modern medicine, modern clinical trials, willing patients who support this work, it's really exciting, and it shows you what we can do. You can only imagine 10 years from now, and certainly another 100 years from now, how we'll be doing all of this stuff. So thank you very, very much.
Thank you.